So in this video, I'll break down 3 common situations where surgery might actually be necessary. And in the end, I'll share one reversal that helps many people avoid going under the knife. The first case is a disc emergency. A police officer finishes a long shift sitting in a cramped car. At the end of his shift, his back pain is unbearable. Stabbing sensations shoot into both legs. When he arrives home, he realizes his pants are wet, but he can't remember relieving himself. Acute cauda equina syndrome happens when a large disc bulge compresses the bundle of nerves at the base of the spine, the nerves that control your legs, bladder, bowels, and sexual function. If you experience sudden loss of bowel or bladder control, severe numbness in the saddle region, or rapidly worsening weakness in both legs, that could be a sign that you have this emergency. This condition requires immediate evaluation and potentially urgent surgery, without which the nerve damage can become permanent. The second case, the warning zone. A yoga teacher developed sciatica while doing a sun salutation. At first, there's mild weakness in the ankle, but over the ensuing weeks, the weakness progresses to the point she can't lift her foot at all. It just drags when she walks. The second situation that may warrant surgery is called progressive neurological decline. Let's say you have sciatica and the numbness and the weakness increase week to week, month to month. This pattern suggests that the nerve may be continuously degenerating. In these cases, the concern is whether waiting would lead to permanent and irreversible changes, because not everyone recovers all of their nerve function after a surgery, especially when it has been prolonged. So if your neurological function is clearly declining, it's a strong sign you need to see your doctor and consider surgery. The third situation, let's call it the pain trap. Here's what it looks like. A motivational speaker develops spondylolisthesis, one vertebra slipping forward over another. At first, his pain is with standing only. Then sitting starts hurting. Later, lying hurts too. Before he knows it, every position involves severe pain. This type of situation is called intractable pain, and it has 2 defining features. First, the pain is constant and severe. Second, it's unrelenting and doesn't change based on activity or positional elements. And that kind of pain is a red flag. It's seen in the most severe mechanical spine injuries, and it's also seen in non-mechanical conditions that can cause back pain, like cancer. So in these cases, the key is to first identify the true pain source. Here's the big reversal. Now that we've covered the 3 main categories for surgery, let's talk about the gray area where most people actually live and why it's a gray area. More than 95% of disc injuries don't have an absolute need for surgery. I know most of the patients who come in to see me being told they have no other choice, they actually can avoid going under the knife. The key is to receive the correct diagnosis and movement-based treatment plan when it comes to avoiding a mechanically based spine condition. Consider the right diagnosis, the right biomechanical assessment, the right ergonomic corrections, and the right exercise plan can help avert most of these situations. Why doesn't this happen more? Sometimes the clinician doesn't know the correct principles. Other times, the clinician may know the correct principles, but doesn't know how to apply it. But most of the time, there's really a mismatch I'm seeing between the true pain generator and the therapy that's been prescribed to address it. So that mismatch is what gives people who have otherwise been told you've failed everything a chance to actually improve.